this is this is going to be a reflection of a really unique setting that probably not a lot of people
Mhm.
even understand, but something that pretty much every Medicare beneficiary in our country could potentially take advantage of if it was, if it was offered
Mhm.
in their site or location. So I have Kelly Schroeder with us. And she is the director of clinical services from a PACE program in the Milwaukee, Wisconsin area. So Kelly, I'll just let you introduce yourself, kind of explain your background and what you do and what the PACE program even is.
Yeah, thank you. Thanks for having me. So, I am a PT by background, and I stumbled into the PACE program by accident. It was somebody who I worked with in a clinic said, "Hey, you'd be great over here in PACE." So I started about 10 years ago managing the rehab clinics and then became the director of the rehab clinics. And now I am overseeing all our clinical services. So, like our medical clinics, nursing practice, rehab, all sorts of good stuff. So, yeah, it's probably the best mistake I ever stumbled upon.
I
And
think
like
that's the way of
most
it.
people, I had no idea what PACE was when I started.
Mhm.
PACE stands for Program for All Inclusive Care of the Elderly. This is a CMS, it's a Medicare Medicaid program that is offered in, I believe, 32 states right now. There's about 148 programs, about 60,000 participants in these programs. And really, what it is a program for people who are 55 and older. They are eligible to enroll, and it provides a comprehensive medical and social services to our elderly participants in the community. And the goal of this program is to keep people in their homes to age in place. Otherwise, the people in PACE programs actually are at a functional or medical level where they probably should live in a nursing home. So the whole goal is to help people age in place. And we do this with an integrated model. We have an interdisciplinary team that includes doctors, nurses, social workers, recreational therapists, PT, OT, home health, transportation, behavioral health, our own internal pharmacy. So, just really a diverse group of clinicians, and we all work together to create an individual member-centered plan around their health, and we look to serve them, keep them in their home, and kind of do whatever it takes to keep them there. We also provide our care out of a day center model. So a lot of our participants come into our day center where they can receive socialization, recreational activities, rehab, restorative care. They have access to our clinic. So it's really, it's a social setting, but also a medical and therapeutic setting
Mhm.
for these folks who otherwise would be in the nursing home.
Mhm. Wow. Yeah. So this is something that is so incredibly needed. And I
Mhm.
remember when we first spoke about this, I was just like blown away by the fact that, first of all, this exists and that I didn't
Mhm.
know about it, and that a lot of people don't know that this type of program exists,
Yeah.
and that it's CMS led and run. And
Mhm.
so I'm curious about, like, how long has this program been out there?
So our organization has actually been around for over 40 years. We were one of the first to offer PACE in the country. PACE originated on the West Coast out of San Francisco. We offered other services before PACE came to be, but we had a founder who really just saw a need
Mhm.
to help our frail elders age in place and keep everybody at home.
Yeah. Okay, so this I have like a million questions again, even though like we actually did have a discussion before and where I was asking a lot of questions about this, but I
Mhm.
still feel like there's so much more to know and so
Mhm.
much more to learn. So since this is a primary care uh
Mhm.
themed series, it seems like the services that y'all are offering are very much like primary care related, from covering
Yeah.
a variety of disciplines, medical, physical, functional,
Mhm.
social. So just tell me a little bit about what the first of all, who the average patient is
Mhm.
that comes in, that
Yeah.
y'all find or that is brought to you. And so yeah, start with that.
So the typical person, is 55 and older.
Mhm.
They usually are at an income level below those poverty lines. It's
Mhm.
they're Medicaid eligible, and have to be financially eligible to be in our program.
Mhm.
In our particular area, we serve a group that probably has had limited access to
Mhm.
healthcare in
Mhm.
the community, who has probably some factors related to their social situation that has made access hard, or even affording certain healthcare and social, things like transportation
Mhm.
and equipment or anything they might need to stay in their homes, or supportive home care services. So they're usually quite frail,
Mhm.
quite sick, and really have had not a lot of access
Mhm.
in the.
Yeah, so let's say a patient or a patient comes in and they have never been with you before. What does their initial intake look like, and what types
Yeah.
of providers or professionals are they seeing initially? What types of questionnaires are they filling out? What
Mhm.
um tell me a little bit about that process, about how they're received into the system.
Yeah, so in our state, it's a little bit different. We are the only state where we have aging and disability resource centers that options counsel our participants into our program. So once they have selected the PACE program, they actually, it's quite a comprehensive intake process. They have to meet with every member of our team, and every member of our interdisciplinary team does an assessment. So
Mhm.
they'll meet with primary care, they'll meet with nursing, social work, PT, OT. We do an initial assessment, and then we put all that information together, and with the member come up with their care plan, the most important areas they want to address. And then we kind of, at intake, see what supports do they need to get in place immediately, and we kind of start that process, whether it's transportation for various medical appointments if they haven't been followed up, um, by maybe a specialist they need to see,
Mhm.
any DME, and then some of the other things like Meals on Wheels,
Mhm.
um, pharmacy, delivery services, assistance with grocery shopping, all that stuff.
Mhm.
We kind of come together and get that all in place for them.
That's awesome. So so how long does the initial intake last? So for example, if a patient comes in for
Yeah.
the first time, are they seeing primary care and all of these people all in one day, or is it like scattered along? Is
Yeah.
it a long process?
It can be sometimes to make it a little bit easier. We know that it's an overwhelming process for the participants. We'll maybe try to see them together in rehab. Maybe the PT and OT might go out together because there is some overlap, and we both want to see how they're moving in their home, for example.
Mhm.
Um, the nurse might see them, and then primary care. So they kind of piggyback off of each other. But it is kind of a long process. So we used to try to do it all in one day, and they just come into the center and see everybody. But that's a little bit overwhelming. So it can be a little bit spread out now.
Mhm. So when you said you like to see them, you like to see how they're moving in their home.
Mhm.
Are you actually doing a home visit for an eval?
Yeah, so one of the things that we do, in our rehab department, we thought it was really important to see how people move in their environments to really get a good idea. Some of these homes are very, they're in very poor neighborhoods and very poor condition.
Mhm.
um, steep stairs to get in and out, really
Mhm.
small bathrooms. So we like to see that for ourselves.
Mhm.
So we actually do our intake in the home, and then we actually do an annual evaluation, an
Mhm.
annual checkup visit.
Mhm.
And we don't do those in the home too, if we're able to, just again, to see how they're moving, if we can modify the environment, get them some equipment. Um, then we can really see the functional changes that might lead them to not be able to stay at home, and we can get ahead of things and try to be proactive in our treatment.
I think that that is phenomenal. And so I'm thinking of like some of my former patients that, were, they had insurance plans and it was all good to go and whatever. So I'm thinking of when I was when I had my own cash practice when I lived in Pittsburgh. I was working with a patient who was about to have hip surgery, and I was like, you know
Mhm.
what? Let me just like let's do a home visit just so that I can actually see how you're going to get around your house with crutches. And this was like a young, able-bodied person who, just she had FAI and she was about to have hip surgery. And just seeing like what her home was like, the super narrow stairs, the shower and tub that like her and her husband were going to have to figure out like how to get her in and out of the bathtub with crutches, within her limitations. And I was like, there are so many things that I think that we as providers and just healthcare professionals in general that we're missing by not seeing what a patient is like in their own environment and in their own home or workspace. And so
Yeah.
that is incredibly invaluable. And I think it's so awesome that your program, allows you to do that. I think that's like that's got to probably save so much that probably saves money for
Yeah.
CMS, because you're actually identifying risk around the patient's normal environment. Whereas if you see them in a clinic, you might not be able to identify all of those things. Um,
Yeah, absolutely. That's the whole premise of this program
mhm,
is, we receive a capitated rate to
mhm,
keep to take care of people.
right.
And they do it because CMS and Medicaid see a cost savings to it because we
Totally.
are being proactive.
Mhm,
And it's hard to address medical needs without addressing the social needs people have. So,
absolutely.
if we go out to these homes and these are people who don't have a lot of money,
Mhm,
they might not even have furniture. So
yeah.
where are they going to sleep after they have this hip surgery? Maybe they've been sharing a bed with somebody else or sleeping on a couch. And is
Mhm,
that really going to work when they come home? So, we can look at DME, or our social workers can work with local agencies for furniture vouchers and
yeah.
things like. So yeah, it really is just an excellent model to be proactive and see
Yeah.
people and meet them where they're at.
And yeah, and so another thing that you had pointed out, because we had met when I was teaching my primary care course at the APTA Wisconsin's meeting, and one of the things I go over in my primary care course is my intake form, and I am so glad that you pointed out some of the discrepancies in my intake form. One of which was food scarcity, and just do you have access to food?
Yeah,
Do you have do you have the basic needs that you need? Because you
yeah,
you can't just by the way that somebody is dressed, the way that they carry themselves, you can't know everything about that person. And
mhm,
it's wrong of me, or wrong of like any of us or all of us, to assume that somebody has access to the basic needs of living. So
right.
I was just like so grateful that you brought that up. Do you want to talk a little bit about that and about how, maybe your experience has evolved since being a part of this program?
Yeah, I think when you're doing an intake, I like you said, you just can't take anything for granted that people have access to all those things that you assume are basic needs, but they might not have access to it, whether it's a safe sidewalk to walk on or even a safe neighborhood to go outside,
Mm-hmm.
safe housing and stable housing, living with family and friends who might be bringing drugs or weapons and gang activity into homes, living in a city where it's a food desert.
Mm-hmm.
There's, and if you want to get fresh fruit and vegetables, you might have to travel 20 or 30 minutes to
Mm-hmm.
get there, if you can get to the bus,
Mm-hmm.
and afford to go on the bus. So it's really opened my eyes. It's the social determinants of health are just as important, I think, as those medical ones. I had a mentor who once told me that you cannot self-actualize in a wet bed. And that kind of sums up our program. It's taking that Maslow's hierarchy, and if those basic needs aren't met, they don't care about doing their exercise 3 times a week or 10 reps or whatever. They got other things to worry about. So, um,
Yeah, I mean, absolutely. Like I think that it's just it's a really good check for somebody like me who especially over the past few years where a lot of this has been just more pressing in the news and in media, and it's just been more highlighted. I am definitely a person of privilege, and I am so much more aware of that, and I'm so much more aware of the things that I have, being grateful for them, but also recognizing and reflecting and educating my children on the fact that like some other children their age might not have a safe place to go home. They might not have a warm bed to sleep in at night. They might not have food to eat. And
right.
I'm just so much more aware of that. And I think that it has definitely made me a better person, a better therapist, a better mom, wife, whatever. So
Yeah.
I just am so appreciative that not only that this program exists, but that, that the social determinants of health have really been highlighted,
Yeah.
in not only in like the medical literature, the physical therapy literature, but also just in the media and in the communities. And I think that that is so important for, recognizing it's just incredibly important. And you're totally right. Like, why would anybody care about, taking, dosing their medication appropriately, or, doing their home exercises when like they are exposed to violence on a regular basis, Um,
Right.
yeah.
Yeah.
So tell me a little bit more about the interdisciplinary team that you have and what it's like working with each of those team members on a regular basis, how you communicate with one another from the get-go and then throughout the course of somebody's care.
Yeah. So, the team meets every week to go over care plans that they need to work on, any new issues. There's morning calls to go over any requests for maybe equipment or services. And then kind of in between, they're just always communicating. We're not always in the office like we used to be. So we're doing a little bit of telework, so email, and we have a instant messaging service, and picking up the phone. They're constantly talking to each other, but we do have those weekly team meetings where we can address issues or talk about concerns for members.
Mhm.
And then another um, another thing that we do at our organization, we do reflective practice. So if we have an episode where things maybe didn't go how we thought they should, or we're not, something happened that maybe shouldn't have, we will get together and review what happened to see what we can learn and do better for next time to make sure the same thing doesn't happen again.
And are you able to give any examples of something like that?
Um, we if somebody is hospitalized, maybe for an error in their care or not receiving their medication appropriately, we have a obligation to report certain things to CMS when we have certain incidences. Um, Falls would be one. So if they have a fall with an injury, we have to file an incident report. We have to report things like that.
Mhm.
And then we might come together as a team and see, okay, what's happening? Why are they falling? Why did they have this injury? What can we put in place to prevent this from happening again?
Mhm. And just to reiterate the team members, so you have a physician or primary care provider. Is it a physician
Mhm.
or a mid-level?
It can be a physician or a nurse practitioner.
Okay.
Sometimes they share a team, so our members might alternate between seeing one or the other.
Okay. And then you have a primary care provider,
Mm,
nursing staff, uh,
yeah.
PT, OT, and social work. Is that the whole team?
No, we have a transportation coordinator, we have a day center coordinator, we have home health, we have our site leaders. We include behavioral health on our teams, even though that's not part of the PACE model. We offer several programs at our company, and we have behavioral health resources available for all programs, for all participants at community care. And then let's see, we have a dietitian. Um, I'm hoping I didn't forget anybody.
Mhm.
Then we have our
Pharmacy,
medical, we have pharmacy,
clinical pharmacist.
we have a clinic, a medical clinic so we have triage nursing and visits available there.
Mhm.
We have CNAs in our day centers that can assist with restorative, that can provide bathing, a rec staff that does activities in the day center. So it's a very comprehensive team.
Okay, awesome. So this is bringing up an interesting, like, I'm almost, it's I'm glad that this exists, but I'm also getting a little bit upset because my whole one of my biggest passions and where I feel like we can do better in the healthcare system is by making primary care more robust. So I understand that the PACE program has very specific eligibility criteria, which
Mhm,
is perfectly acceptable, and it should be specific to those individuals that have those unique needs. But primary care typically for Medicare is, held by one provider, one, physician or mid-level. And they don't typically recognize team-based care or the team-based care model, with the exception of primary care and behavioral health working together in the primary care setting, where they can bill,
mhm,
these collaborative care model codes.
mhm.
So I am so interested in getting more physical therapists, and physical therapy. I think like the perfect team in a typical primary care clinic would be like a primary care physician, a a behavioral health specialist, a
Mhm.
dietitian, a physical therapist, and a clinical pharmacist. So those are kind of like my five people that I'm like, okay, those are some individuals that can really take care of most of the basic primary care needs. So
Mhm.
how come if Medicare or like CMS recognizes that this model is saving them money in this particular population, I just wonder, if and why they don't recognize it or they don't promote this type of model across the board in primary care. What are your thoughts
Yeah,
on?
I don't know why they do, especially with some recent, I think I just read an article, with all the preventative measures and tests that primary care is supposed to do, they'd be working more hours than there are in a day. It's just not even feasible for them
Mhm.
to do it. I don't know. I think just in general, people don't understand what a physical therapist can bring to the table.
Yep.
I often surprise people when I speak about different clinical things that I might know about related to primary care type stuff when we are talking about members.
Mhm.
They just think of us as kind of like people walkers and exercise doers, and and don't understand just the depth of the knowledge we have to help manage these chronic diseases. I mean, if exercise were a drug, we'd all take it, right? Like,
Mhm.
what is exercise not good for?
Mhm.
It helps everything. It helps all the things, the chronic diseases like diabetes, obesity, heart disease that we're seeing, that are prevalent, dementia. There's
Mhm.
tons of research. Why are people with dementia and Alzheimer's and mental health issues not coming to primary care? They do it in other countries. I'm not sure why we don't do it yet.
I
So,
know. And so this is my whole mantra is like we have 330,000 physical therapists in the United States. I think I mentioned this in Commander Turner's episode as well, but we have 330,000 physical therapists in the United States, and
Mhm.
primary care, so family medicine. So, okay, let me back up a second. We have that many PTs, yet only the research shows 7 to 14% of anybody with any sort of functional or neuromusculoskeletal complaint ever sees a physical therapist.
Mhm.
So all of this is supposed to be managed by, I don't know, primary care. So primary care, they have 206-ish thousand family medicine providers, add another, or family medicine physicians, add another like 90,000 for PAs and nurse practitioners in the primary care space. There's supposed to be like a 50 plus thousand uh, sh- uh, shortage of primary care providers by the year 2025, which, oh, by the way, is less than 2 years, like 2.5 years away from now.
Mhm.
So if physical therapy and behavioral health and dietitians and other people that can sort of assist with some of those insane requirements that primary care physicians are supposed to take in the primary care space, why in the world are we not doing it? I mean,
I
it blows my mind.
I don't know. And what you didn't mention is the lack of mental health care
Yes.
providers or two.
Yes.
And so that's the cool thing about the PACE model is we can tailor our programs to what the evidence kind of says we should be doing, and it allows us to practice in the full capacity of our scope. So
Totally.
one of my dreams is we have a behavioral health clinic where our members come in and see a mental health provider, but I want to partner our rehab department. So maybe they go to see the psychiatrist, but then they come to rehab because there is evidence based exercise prescription that targets mental health.
Depression
um
is a huge one. Yes.
yeah,
Mhm.
so yeah, I don't know, but we're lucky that our primary care folks really do see the value in rehab.
Mhm.
Even during COVID, here in the COVID outbreaks, PT is really an integral part to recovery and um, just staying healthy to be able to fight off COVID if you get
Mhm.
it. So we were,
Absolutely.
able to have those conversations and embed ourselves in facilities where we had outbreaks to make sure people were still moving, people
Mhm.
were still exercising, staying strong, so our falls
Mhm.
didn't,
Yep.
increase too much. So,
Yep, making sure that they're not going down that dyspnea spiral, where
mhm,
they are so short of breath that they don't do anything, so they just keep not doing anything.
yeah,
Making sure that they are, keeping their bodies moving
mhm,
against gravity so that they're not developing accelerated
mhm,
sarcopenia and osteopenia. Like these are
mhm,
the things that I think that a lot of outpatient therapists we're all aware of it, but it's like we're just so in the habit, and I'm just
mhm,
speaking for general like outpatient ortho, we're just so in the habit of like, oh, we're here to see a knee patient or a low back pain patient, and it's like
yeah,
we can have a humongous role on these population health issues, and just risk prevention, so much
mhm,
bigger of a role there than we can just treating the ankle sprains.
right.
So I love this model, I just love it.
I do too. I am so lucky to be a part of it. It is just such a wonderful model. And to your point, I don't get why more states aren't doing it. I don't know why this isn't everywhere. The New York Times, if you go to the National PACE Association website, the New York Times did an article like this is CMS's best kept secret. And part of it is we're not allowed to advertise. So
Mhm.
that is a barrier. One of the barriers in our state too is that we can't directly enroll, but we want to tell everybody about PACE, but we can't really market or
Mhm.
advertise model.
And what is the reason for that, if you're allowed to share that?
Yeah, we just have some different, so we have contracts with our state and we have contracts with CMS, and how we're allowed to market and what we're allowed to market is limited. Um,
Mhm.
because, especially in our state, Again, members are supposed to go to these aging and disability resource centers
Hmm.
and get the information from options counselors and then choose a program, without having pressure. Um, which sounds good, but the National PACE Association has done, they had kind of secret callers call different resource centers and ask them about PACE. And overwhelmingly, the information was inaccurate, or the options counselors did not really understand PACE and weren't presenting it
Hmm.
the way that they should.
Hmm.
Um, so,
So there's a limitation. This might probably just come back to like typical government red tape that doesn't make any sense. But
mhm,
so there's a limitation on people knowing about the program. There's a limitation on the aging centers presenting accurate information, or being able to refer people into the program, but you're not allowed to advertise.
no,
Okay,
no.
got it.
And
Makes perfect
again, yeah, we're the only PACE program in the country where we can't enroll our own members either. So that's
Oh, because they have to be enrolled through the aging centers.
yes.
Huh.
Mhm.
That's a hiccup. Okay, so do you know of, or have you ever had any like conferences or done any sort of networking or collaboration with other state programs?
Yeah, so it's actually happening in the next week or two. The National PACE Association does do an annual conference, and I
Cool.
have the opportunity to present there. And I actually got to present on how physical therapy and exercise are a key component of Alzheimer's treatment and prevention.
Hmm.
Uh, Talked with different centers about how they could incorporate some of that into their programming. So we do have a conference. There is a handful of us, PACE therapists that go to CMS every year, and um, we'll try to maybe get together and chat. And usually there's like three of us
Hmm.
of all the members at combined sections. So
Do you
um,
have any idea how many total physical therapists are working for this program?
oh geez, no, I don't know. Every once in a while, I'll see something come through the listserv, like how many PTs do you have per member? Um, it tends to vary, one OT PT per 100 to 150 participants. It can vary. Some programs use PTAs, some don't. We're a program that doesn't. Um,
So
some
I am just doing a little test, just real-time test. I just pulled up Google and I
Mhm,
typed in PACE program. Okay, so the
mhm,
very first thing that comes up is the program of all inclusive care for the
mhm,
elderly. So that's cool. So
mhm.
that's there. And I'm just wondering, like, how easy is this to navigate? Well, I don't know how it is to actually navigate through the whole thing. But if somebody didn't like, I had no idea that the PACE program existed. So
No.
if you don't, are other states allowed to advertise their services?
I can't speak to the other states'
Okay.
regulations or what their contracts with their states look like. Typically, if you Google it, it's going to take you to the CMS website. So you're going to
Mhm,
get a CMS manual
mhm,
and all sorts of rules. It will have a general description.
mhm.
Um, but yeah,
Interesting. So there are some, so for those that are listening, and if you know or know of somebody who might benefit from this wherever you are in the country,
mhm,
just on a quick Google search, I also, if I scrolled down after that the very first thing that came up on the Google search, I'm in Illinois. So the one of the second things that came up was, does Illinois have a PACE program? And
yep,
I clicked on that, and there was all this information about how to, you know what the program is, like who to contact, sign up for alerts. So if you're interested in learning more about what types of programs are available in your, wherever you are in the world, your region, maybe
mhm,
just do a quick Google search, because you may come across a patient, or you may come across, you may have a patient or just somebody that you know that
mhm,
tells you about somebody that they know that is in need. And I
Mhm.
just think the more we can get the word out about this, the better it is. So, um,
Yep. And
so
I would
yeah.
definitely recommend the National PACE Association has on their, it's right on their homepage. I think it says something like find a PACE program near you.
Mhm.
So you can type in and where you're at, and it'll show you if there's a program close to you. And there's
Okay.
also some short videos of participants describing their experience with PACE, and you might
Mhm.
get to learn a little bit more about it, more so than on the CMS website, which can be a little more
Yeah.
technical and
There's a
insurancy.
lot of words. It's just a lot of words. So I feel like it needs to be more, probably the other website you're talking about is more patient centered, I'm hoping.
Yeah, yeah. And even, if there's hospital systems or healthcare programs that are interested in starting PACE, there's all sorts of resources on there on how to go through the application process, what you
Mhm.
need to do. There's companies that help consult with organizations that are starting it up. We actually offer a service like that too. So lots of resources for patients, providers, and those interested in actually doing it.
Mhm. Do you have any vacancies? Because
No.
I feel like, yeah, I feel like if I had the job that you had, I probably would never leave because it just seems
Yeah,
like such a first of all, it
yeah.
seems like you have access to the things that you need for your patients, which is
Mhm.
something that every healthcare provider out there has struggled with, you know, probably on a regular basis. I would say on a daily basis, you probably come across a patient that you are unable, insurance won't pay for this, they won't pay for that, so the patient can't afford to pay out of pocket and yada yada. It sounds like
Yep,
you have the access to the things that you need for the patients that need it. And it
yep.
also sounds like it's an awesome job. So
It
I can
is.
imagine that probably people don't leave their jobs once they're in it.
Not many, not many. No, no, and it's really cool. So we have a formalized process that we have to go through, um, by regulation. Essentially, somebody in PACE can ask for anything. Now, that doesn't mean they get it,
Yeah.
uh, but we have a decision-making process where we kind of go through as a team and we talk about, what are some of the options to solve the problem we're trying to solve?
Mhm.
What's the cost of all the options and
Right.
what's going to work the best? And then we can make a decision, and we can, in that capitated rate, we can essentially fund anything we need to keep somebody at home. So we have the luxury to go outside of what is a traditional Medicare or Medicaid
Mhm.
benefit package,
Mhm.
I guess, for lack of a better word.
Mhm.
So there's really obscure things that we we have done, um that just made sense because it kept somebody at home versus having them go to the nursing home, which
Mhm.
is not cost effective and nobody wants to be there
It's
anyways.
extremely
Mhm,
expensive to have somebody in
mhm,
a nursing home level of care.
mhm.
Extremely expensive.
Yeah,
Mhm.
yeah.
So Mhm.
So like one of the things that I remember, we couldn't get people maybe orthotics or orthopedic shoes just so they could remain ambulatory because they didn't have that special diagnoses that Medicare said you needed to have. Well, we can get people shoes and help them walk. So,
Mhm.
it's just small things like that. But
Mhm.
um, if you can walk, you can probably stay at home.
For sure. Oh my
Mhm.
goodness. I think this is incredible. I think
Mhm.
everybody in the whole entire world needs to know about it, at
Mhm.
least in the United States. And what are some other things that you might suggest? So let's say because we have the PACE program. Great, we know about it now. At least now we do. There are plenty of other community centers, nonprofits, lots of other types of programs that might be trying to fill some of these gaps for patients that don't know about a PACE program or don't have access to it, or maybe they're not old enough yet, or maybe they don't meet the certain criteria. But these other types of organizations want to offer those services, or maybe start up, a community center that offers these things. I'm thinking of one in particular that just opened.
Mhm.
What would you say to those people who are trying to start up a program like this, even if it's on a much smaller scale, maybe lower funding? what would you say to them to help them, get started?
Oh
Probably a
boy.
big question.
That that I don't know what I would say to them to get
Mhm,
started.
mhm,
Um, I think, you know, part of it is recognizing the community and the group you're trying to serve
mhm.
and ensuring that what you are bringing to the table meets their needs and not
Yes.
just some
Not just what
general.
you think they need.
Yes, yes, well, preventative task force says we need to do these things, so that's what I'm going to offer, and that might not be what the community needs.
Mhm,
We it works better when you're part of the community you're serving
mhm.
rather than kind of swooping in and trying to make them conform to what you think it should be, I guess.
Absolutely. I love that. That's a great that even just so as simple as it is, that is a great
Mhm.
answer because I think that sometimes, some people go into, various communities or I'm even thinking about some of the humanitarian crisis in Ukraine and Russia, what's going on with the hurricane in Florida that just happened. There's humanitarian efforts and, various nonprofits and organizations that try to help and assist, but if they don't have any understanding of what is actually happening, they could bring in all the services in the world, but it's not meeting the needs of the people that are right there. So being able to conduct some sort of needs assessment before you start a program like that and be really engaging and being a part of the community is so important. Okay, so what are three questions, screening questions that you would tell a physical therapist or occupational therapist to include in their screening that might help cover some of these social determinants of health that maybe we're really not thinking of or we're not doing on a routine enough basis?
Yeah, so I I go back to my psychology training. I have a psychology degree. I ask questions about the base of that pyramid, I guess the Maslow's hierarchy. Do they have those things available? And if they answer no to any of those questions, that's where you need to start. They will never progress or get where you need them to be if they're not safe, if they don't have food, and or they're worried about money, and they don't have transportation to get there. They don't. That's what's going to consume people's worries. That's what's going to consume their minds, and they don't have the energy to think about that
Mhm.
higher level stuff. One of the things we've added to our intake too is I think when I first started out, I was like, well, here's your exercises, go home and do them. And if you don't do them, you're just not compliant, right? We like to use that word a lot in
Ugh.
medicine, not compliant, not
Mhm.
compliant. I hate
I hate that. That needs to be
um
abolished.
I know. So we like to ask people up front, what are their beliefs about exercise?
Mhm.
What are they willing to do? What are they capable of doing?
Mhm.
And how do we work it into what works for them? And again, not just projecting what we think they should be doing.
Mhm.
When I have staff tell me, oh, they're not compliant, I said, I just look at them and I go, really? So you do every darn thing your doctor tells you to do? I
Mhm.
don't.
Mhm.
And then I do what I can. I do what I have time to do, and I do what's important to me, right?
Mhm.
So to give people grace when you're kind of,
A
you know,
110 gajillion%. So I think that as a novice clinician and
mm,
somebody, coming right out of PT school where you're learning all the evidence and you're learning all the stuff, you're like, oh, well, somebody with tendinopathy needs to do this much loading in this particular circumstance to do this. And it's like, okay, whatever. Like, and you hit the nail on the head when you said you start by asking them, what are your beliefs about exercise? Like that is the perfect way to sort of tee it up. And that's really the foundation of motivational interviewing too. You
yeah,
figure out what are they capable of.
right.
Like I remember when there was like the KDO break before having kids and then after having kids. And it was like after having kids, um, Yeah, I have this much time to do maybe one or two exercises, like when my babies were really little. Um, and I just remember like talking about that with somebody else and just being like, wow, the way that I educate my patients now that I have this frame of reference of like what insanity of life is like versus what it was like when things were simpler. Like I
Yeah.
understand that so much more now. And I think that's part of the art of practice is being able to meet your patient where they are, not where you expect or want them to be. So this whole
Yep.
issue of compliance or like not being compliant, like I just hope I never hear another therapist or healthcare provider like say like, oh, the patient's not compliant. So well, then you probably weren't giving them something that was realistic for them.
Right, right. And I had to laugh. I saw you had, was it on Instagram or something? You were posting doing your exercises. Like I
Yeah.
think I broke my ankle and I was doing my exercises while I brushed my teeth,
Mhm.
while I and so I try to think of how can I incorporate this into their life. So, for our elderly folks, I always my belief is that you need to be able to sit and stand to get off of the toilet and out of your chair. Otherwise, that is like a really something that's going to deter you staying at home, right? So, okay, you don't want to exercise or be active, but will you sit up and stand down 5 times during the commercial break, 5 times a day? I usually get a yes.
Yeah. Okay. I can do that.
No, I don't, I will take what I can get.
Absolutely. Because I think sometimes we are like, oh, well, you're not meeting ACSM guidelines for exercise. And it's like, well, who is? Like, most people are not. And like fitting that into our crazy, I don't know who came up with this 40-hour work week, but like, whenever, seriously, like, because other countries have other models. And
Yep.
they also take, a month of vacation in the summer, and that's normal. That's cultural. So in the
Right.
United States, we're like, oh, well, 40 hours is minimum and you're not working really hard unless you're working 60 or 70 or whatever hours per week. And it's like, something's got to give. We're all going to get way more unhealthy the more we like work and press and do. And
Mhm.
so, yes, meeting your patient where they are at is the epitome of empathy and the epitome of good care. Like you're not going to be able to be that patient is not going to be successful in achieving their in progressing toward their goals unless you work with what their goals are and what their capacity is, not what you want
Right.
it to be.
Right. It's kind of like, when the doctor's like, oh, you should lose weight, eat better, like
Oh, that's
maybe
helpful.
have a I I like snacks. Maybe maybe I don't want to, but
You know what? And so like that I'm glad that you brought this up because I'm going to give a shout out now. So Dr. Natalie Gentili, she was actually my primary care doctor in Pittsburgh, best primary care doctor I ever had. And she has this if you follow her on Instagram, I think she's just at Natalie Gentili MD, last name spelled like Gentile. If you
Mm,
follow her on Instagram, she talks a lot and does all these videos about how there's so much more that doctors can be doing for their patients with their weight loss or with their health goals than weighing them and telling them to lose weight, because you can't, like, for a patient that is obese or that is overweight, you can't just put every single problem that they have, every joint pain problem, every gut problem, every this and that, and just say, oh, lose weight. Like, that's not helpful. And
no,
so
dismissive.
it's so dismissive and it's so um it's just not right, and that is not going to motivate that patient to do, like, work with one thing, find one thing. Can you,
Mhm,
get up and walk for 5 minutes, because
mhm.
that's going to be better than what you're doing right now. Meet them where they're at. And that's something I've always been a big proponent of ever since I learned how to think that way.
Yeah,
And that's something that I think Dr. Gentili is really, really a big proponent of. And I was so glad to hear you bring that up too. So I hope that more and more just PTs and healthcare practitioners are filling that mold for sure.
yeah. And I think I read a book once. It's called the One Thing, and I think that shaped how I practice too, because you can't put, one thing on top of the other, on top of the other, on top of the other. You have to to focus on one thing that's doable in this space and time, and focus on that.
Mhm. Yeah.
And you don't get to pick what the one thing is either.
Mm-mm. The patient has to be the one to tell you what they can achieve, what they can accomplish.
Yes.
So
Yeah.
great points on that.
Or-
Any other parting words of wisdom or thoughts, things you want to share about the program or anything like that?
Um, it is an amazing program. If you're in a position to, as a healthcare leader, to think about offering it in your community or in your healthcare setting, I highly recommend you explore it. It is, in my opinion, what healthcare should be.
Mhm.
It's a program that was probably ahead of the curve,
Yep.
realizing that social determinants and health medical needs go hand in hand, and that the team-based approach really is a great model,
Mhm.
really a great collaborative model, and the mission we have to keep people in their homes. I mean, who doesn't want to age in place?
Absolutely. Yeah,
Who
for
does?
sure. So one final question that just popped into my head was, if I were, or if any of our listeners are currently in, a hospital system or a region that doesn't really have access to PACE, is there
Mhm.
a way for them to go about setting a program up if they don't currently have one, and who should they contact and what do they do?
So again, I would refer people back to the National PACE Association. There are tons of resources on starting a program.
Mhm.
It's not easy work. You have to, so not only are you a care provider, but you're also an insurance company at the same time.
Right.
So you have to have all your ducks in a row. You need to have a provider network and things like that. Um, but again, the National PACE Association really does have great resources, and sometimes even classes for entities that are interested in starting a PACE program and helping them with the paperwork and the setup. I know I've collaborated with different rehab departments in the country when they've started their PACE programs, and we just kind of talk through operations and processes and things like that for
Mhm.
having a PACE rehab department. So um, there's definitely a community that's out there to help help get you started.
Yep, for sure. So I actually, again, just real time, did a Google search, National PACE Association. So the website is npaonline.org. Is that right?
Yep.
And actually, one of the first things across the bar, the top bar of the website is start a PACE program, and then there's all of this stuff, understanding the model, assessment tools, financial planning, technical assistance centers, application process. There's all this stuff there. So if this is really resonating with anybody who's listening, npaonline.org is definitely where you want to go, because you're totally right. This website is way more friendly, even just to look at. So
Yes.
usually it's easier to navigate in that case. There's education, member resources, policy
Yep.
and advocacy. There's all great stuff there. So
Yep.
well, thank you so much, Kelly. I really appreciate your time today. Um, any other last thoughts or words before we wrap
No,
up?
been my pleasure. Thank you for spreading the word about PT and all the awesome things that physical therapists can do.
Thank you. Really appreciate it. Thanks for listening to the Redefine Health Ed podcast. Support our mission of getting more rehab professionals integrated into primary care by visiting redefinehealthed.com, subscribing to our email list, following us on social media at Redefine Health Ed, and taking one of our courses. All podcast listeners can save $50 on our Foundations for the Primary Care Therapist course or the Master Musculoskeletal Imaging certification by entering RHE Podcast, all lowercase, into the promo code section of the checkout page. Until the next episode, stay awesome, y'all.